Next, what kind of germ is engaged? Mycobacterium tuberculosis, Pseudomonas aeruginosa, Proteus, mucosal streptococci. And if these microorganisms maybe antibiotics which we use, it's not affected for these microorganisms. A dysfunction of the auditory tube caused by chronic rhinitis, adenoid vegetations, thickening of the posterior edges of turbinate bones, nasal polyps. These which disturb for the good functions of the auditory tube. And these predisposing factors we have to remove. How we can remove? For example, if children has adenoid vegetation, we should recommend to parents of the patients to perform the adenotomy. For example, nasal polyps, if present, polypectomy. If the chronic rhinitis, we have to treat the rhinitis, sinusitis, tonsillitis. If the DNS, deviation of the nasal septum, we have to do the submucosal resection of the nasal septum. That it means that nose and the throat mustn't disturb for the function of auditory tube. Okay, next, presence of the organism sensitization, which supports the inflammatory process in the ear and its transformation into the chronic one. Constitutional peculiarities and hereditary program. Okay. Yes, also nasopharyngeal carcinoma in adult unilateral. Yes, of course, except predisposing factors is a lot. For example, these benign and malignant tumors in nose, yes, or maybe nasal pacing, yes, anterior and posterior, cleft palate, yes, in this case also will be mostly who has cleft palate, exudative otitis media, mostly they have. And adenoid vegetation also. When we ask chronic otitis media, with which three main symptoms characterized, mostly students confused. You have to know if past discharges more than 3 months, it means continuous past discharge from the ear. Second one, perforation, persistent perforation of the eardrum and hearing loss. It is 3 main signs of chronic otitis media. For example, why will be persistent perforation of the eardrum? You know, eardrum, it has 3 layers. Outer is epithelial layer, inner it is mucosal layer, and between it is fibrous layer. And when will be reparative stages is restoration stages. Outer epithelial and inner mucosal layer, their reparative stages will be faster than fibrous. And round of the yes, restored by 2 layers, yes. And around of this perforation, it will be permanently some of the not scar tissues, but permanently only 2 layers reparated and not close the this perforation. That is why we perform the myringiotomy. Yes, for example, now I can demonstrate. For example, the tympanic membrane. Yes, and it has the 4 quadrant stuff. For example, this one, And if we perform myringectomy or paracentesis, for example, we perform incision, yes? After that, they're easily closed because this is the close. But if will be perforation occurs, which is that you can see it's perforation, yes? When we damage something, yes, we not sharply, and after that, it's not closed properly, and maybe small perforation occurs, or if continuous pus discharge around of it will be permanently perforations, and day by day, year by year, because patients may be not attentive, and perforations, it will be larger and larger. And if, for example, like that will be subtotal perforation of the tympanic membrane, handle of malleus only present, and this. Okay. That is why 3 main symptoms. Okay. Next. Also, it has 2 types of chronic suppurative otitis media: tubotympanic, purulent otitis media. Tubotympanic depends on the name. It means that mostly anterior inferior part of the middle ear. It is the anteriorly auditory tube, abstention tube, and tympanic cavity, mostly mesotympanum affected, mesotympanum involved, and we can call mesotympanitis. Chronic ectoentral type or suppurative otitis media. Ectoentral, it means that where the ectic and the entral, mostly posterior superior part. Yes, posteriorly it is the entral, and superiorly it is ectic. Or epitympanitis, epitympanum when affected. That is 2 main types. But third is maybe epimesotympanitis, when all the structures involved. For example, in mesotympanitis, this is the tympanic membrane. Okay, this is, you can see, perforation always central. In mesotympanum, mostly in pars tensa, this is the perforation occurs. Is anterior, posterior, or inferior to handle of malleus, or subtotal extending up to the annulus. Subtotal until this annulus tympanicus, it will be. Middle ear mucosa pale pink and moist or normal, but when inflamed, it looks red, edematous and swollen, and occasionally with polyps. Usually polyp, it extends from the mucosa, and usually it is the after inflammation, this is the polyps occurs, and yes, okay. Mostly polyps extend from the medial wall of the tympanic cavities. Okay, this is the also view of the tympanic membrane. Investigation. We use microscope. It helps to determine, to check the tympanic cavity, if granulation, ingrowth of squamous epithelium, also the status of ossicular chain, because sometimes maybe incudostapedial joint mostly leases, and cerebral deafness element may be present. Так. Next, culture test. Of course, very important it is culture test, because we should know, first of all, which is the microorganisms, and which antibiotics is sensitive, because maybe patients used the antibiotics and it's not effective, and we have to bacteriologically laboratories has to determine what is it and which sensitivity. Next, mastoid X-rays, CT scan of the temporal bone. Mastoid process, depends on the development, will be 3 types, yes, well pneumatized, diploitic, and sclerotic. In chronic otitis media, mastoid is usually sclerotic, but may be pneumatized with the clouding of air cells. There is no evidence of bone destruction, which is the feature of eticoantral chronic suppurative otitis media. What about the treatment? The aim of treatment is to control the infection and eliminate ear discharge, and at a later stage, surgery may be done to assist hearing loss. Oral toilet, all discharge and debris from his ear is removed to enhance effect of topical antibiotics. Ear drops, ciprofloxacin, ofloxacin, levofloxacin are used, depends on the culture test we told. Systemic antibiotics in chronic case usually we not use, only in acute cases. Mostly in chronic, topically we use the treatment. Precautions. Avoiding hair washing water in ears or blowing nose hard can be helpful. Surgical treatment. Polyps in ear or granulation is removed to facilitate ear toilet, though avulsion is strictly avoided. Treatment of contributory causes, corrects of infection of adenoids, maxillary anthra, and nasal allergy. Yes, we told. Reconstructive surgery. Once ear is dry, myringioplasty without osticular reconstruction. If the patient needs in osticular reconstruction, we perform it, and closure of perforation can stop recurrent infection. It is hearing improving operations when after chronic, when will be reparative stages and the patient's ear dry, but dry must be ear for 6 months, more than 6 months, and the auditory tube, eustachian tube, also must be functioned well. Okay, next, epitympanitis. What is it? Perforation is localized in the pars flaccida of the eardrum. Yes, whitish cholesteatomic masses prolapse through a tympanic membrane defect. Mesoepitympanitis, you can see it's the sometimes absent the tympanic membrane, a little bit only is near the annulus is present. Subtotal eardrum defect from the upper part of the tympanic cavity. So cholesteatomic mass, this is the whitish mass, is cholesteatomic. And so this is the granulation tissues or the polyps is together with this epimesotympanitis. Bacteriology. Aerobic Pseudomonas aeruginosa, Proteus, E. coli, Staphylococcus aureus, anaerobic Bacteroides fragilis, and anaerobic Streptococcus. And also one of the important causes in acute otitis media, pus without smell, because it's mucopurulent. It's involved on the inflammatory process, the mucosal layer of and mucoperiosteum sometimes. But in chronic, it will be destruction of the bone also, usually in cholesteatoma. It is destructed the bone. The bacteria also is the different. Yes, for example, Staphylococcus aureus, Pseudomonas aeruginosa. They has the smell and full smell. This is the because it's the carriers of the bone destruction. That is why patient with the chronic, mostly who has epitympanitis, the pulses is the full smell has. Okay, where the other here. Okay, I was afraid of where my slides. Okay, this is the cholesteatomas present, and in your book you can read different theories of formation of the cholesteatoma is present, and usually cholesteatoma is located in epitympanum. And you can see this is the mastoid antrum and the attic, and sometimes is located in attic and antrum, and in some cases all the mastoid process is involved. And cholesteatoma, it is the not tumor, it is the in wrong places. It's present the whitish masses, which has the okay, some of the group asked me to share this lecture PPT. Okay, I will send to your leaders of your group. Okay, and to mail, and your leaders can send for your group mates. Okay, cholesteatoma contains germs, yes, germs of microorganisms. Yes, it is keratinous masses, and it has also mucopolysaccharides, cholesterol, enzymes, and it may lyse the auditory ossicles, affect the walls of the tympanum and labyrinth, result in labyrinthine and intracranial complication. Because we told it is located in the attic, yes, in attic and antrum. This is, and you know, superior wall, it is the tegmen tympani, yes, it's the thin bony plate, and if distracted to this bone, and this cholesteatoma can spread, extend to the middle cranial fossa, and will be intracranial complications. It's not in one day cholesteatoma formed. It maybe has, if chronic otitis media for long times, it's, and it will be 10 years, 5 years in this period. And in one day, like that bomb, it's in one day will be this complication. Next, symptoms of epitympanitis or eticoentral: ear discharge, scanty but always full smell due to bone destructions. I told yes about that. Hearing loss, ossicular destruction cause conductive deafness, sometimes sensorineural, but hearing is normal when ossicular chain is chain. And bleeding, it may occur from granulation or the polyp when cleaning ear. What kind of signs? Perforation, either attic or posterior superior perforation. Next, retraction pockets and invagination of tympanic membrane is seen in attic or posterior superior area of pars tensa. Cholesteatoma, when we can see visible, or during oral toilet we can see purely white flakes of cholesteatoma can be sucked from retraction pockets. Otoscopy. Yes, the presence of perforation, marginal or central of the tympanic membrane, purulent discharge, presence of granulations, polyps, cholesteatoma, diminished hearing, yes, pure tonogeometry. It's will be gap between the osseous and ear conduction in the area of low and medium frequencies, X-ray of mastoid, CT, bacteriology culture test. Outcomes we will okay, you can read. Types of sanitary operation in ear. If cholesteatoma occurs every time, we have to do the surgery. Without surgery, conservatively, if we use some of enzymes, for example, trypsin or chymotrypsin, it's not effective. We have to do the sanation of the infection, and it will be general cavity sanitizing, hearing preserving operations, conservative radical operation, expanded radical general cavity surgery when the cholesteatoma is large, and we first of all we perform the behind of the auricle, we perform the incision. Yes, of course, this is operation. We separate the soft tissues, find the Macaron triangle. You know, it is the sign for antrum, location of the antrum. First of all, we have to perform the antrotomy, open the antrum. After that, due to the agitus, we drilled and opened the attic. Yes, mastoid ear cells. Of course, the different types of the depends on the author's stachia and the different types is present. And eticoantrotomy, we perform separate eticoantrotomy with tympanoplasty, and eticotomy we perform. This is the how we can do these operations. We use the drills, and we have to be careful because near posterior wall of the extra-auditory meatus, you know, it's located at the facial nerve. Yes, and if we cut this facial nerve, there will be complications. Of course, we use tympanoplasty. We told if the hearing improving operations, ear must be dry for more than 6 months, no cholesteatoma, no this is present, and if only tympanic membrane perforated, change of ossicles is normal, laryngoplasty perform, or first stages, types of tympanoplastic operation. Closure of perforation in pars densa. We can use graft fascia, temporal fascia. Usually we perform for the artificial new tympanic membrane. This is the first type, endaural myringoplasty, when the only tympanic membrane absent, but malleus, incus, and stapes is present, performed in the presence of perforation in the eardrum and normal functioning of the auditory ossicular chain and auditory tube. But since the neural hearing loss, if it will be all mixed, these operations is not affected, because if, okay, this is eardrum, new eardrum, help to the conduction of the sound, but if cochlea can't receive this, of course not affected. Only it's a help for the avoiding of recurrence of otitis media. It can help, because if patient with perforation, swimming and diving, after that again and again it will be recurrence. Tympanoplastic second type, it is carried out in the presence of defect in the head, neck or handle of the malleus. For example, malleus, we can place on the incus. Here you can see directly it's spread to the incus. Weisstein classification. Yes, of course, this is the classification of Weisstein. Yes, good. Tympanoplastic type 3, performed when malleus and incus absent and flap transplant feet directly to the head of the stapes, because this may be absent. Yes, like they do for long times will be chronic inflammation, and so we put this graft onto the directly to the head of the incas. But you should know, patients not here for the normal, yes, normal, you know, at the decibels, 0 till 20 hertz, yes, but it can maybe increase the hearing until the mild hearing. And next 4 types tympanoplasty carried out in the absence of all auditory ossicles is absent except for the base of the stapes. Yes. And tympanoplastic 5 type fenestration of the horizontal semicircular canal. It's rare we perform fenestration of the horizontal semicircular canal performed in the absence of all sound conduction elements and a fixed steps base. You know, this is the membranous labyrinth. All theirs communicate with each other, yes, and so the movement of the fluids, it helps for the basilar membrane movement, and we'll be hearing. But it's very rare we perform these operations. Okay, now we can see that time is over. Yes, not perfect, no cost, but yes, of course, so it's good. Thank you. Thank you for your feedback. Yeah.